Okay, everyone, I think we'll get started. Thank you all for coming in person, and thank you for those on Zoom as well. My name is Margaret Hayden. I'm a primary care doctor at UVA and faculty at the Center for Health, Humanities, and Ethics. Just briefly, before I introduce our guest, I want to share some information about claiming CME credit for this event, in which the key info is this code here. 27599. So for those of you who want to claim credit, you can use this code for up to 7 days after the event. There's some flyers when you came in too that will have information if that's helpful. For those of you on Zoom, we'll have time for Q&A after the event. Feel free to use the Q&A feature on Zoom, and we'll be monitoring that and can ask your questions. We are really excited today to be hosting the author and journalist Beth Macy, who comes to us from her hometown of Roanoke, not too far away. She is the author of several best-selling books, two of which, Dopesick and Raising Lazarus, have focused on the origins of the opioid crisis, the very human suffering involved in our responses to it. In my mind, she writes about people suffering from the throes of addiction and substance use disorders with a humanity and optimism that is so important at this moment. And I see her work as one of the clearest examples I know of how stories can be used to change hearts and minds in powerful ways. I should also note she has a memoir coming out this fall titled Paper Girl, a memoir of hope and family in a fractured America, that I'm personally very excited to read. For those of you who are interested, there'll be an opportunity to purchase some of her books from the UVA bookstore outside at the end of the event as well. Thank you so much for coming, Beth.
Can you hear me? Oh yeah. Oh yeah. I'm a little louder than Margaret. That's a verified fact. Thanks so much for coming. I'm just thrilled to see my dear friends that I met years ago. I'll talk about that in a little bit. And I'm always glad to come back to Charlottesville. I never miss a opportunity to begin a talk by saying, I'm sorry for your loss. I know there are people in this room that have lost folks to the scourge. When I first started talking about the opioid crisis, when Dopesick came out in 2018, I would say we lost 72,000 people last year. 2 years ago, I said we lost 112,000 people last year. Every one of them still a tragedy and still an undercount. Doesn't count other deaths of despair related to addiction. Doesn't count the ones that weren't recorded that way. Doesn't count suicides. Doesn't count the family members and friends impacted. This year, we had a little bit of a bright news. The numbers are starting to come down. We lost roughly 100,000 folks last year, but that is very uneven. Some states, the rate is still going up. Rates among Native Americans and Black Americans are still skyrocketing. And people aren't sure exactly why the overall rate has gone down, although if you talk to harm reduction experts, and I'm going to talk a lot about harm reduction today, they will say it's because of much wider spread distribution of Narcan and fentanyl test strips and something they call drug user mitigation, which is snorting or smoking instead of injecting. But they also stress that they don't trust the government reported numbers, that in their communities, they are not seeing the numbers go down. And in fact, at Virginia Harm Reduction Coalition, where I volunteer most weeks, packing Narcan kits on Monday afternoons, which reminds me of the old quilting bees. We just sit around and stuff kits and chat. 15 overdoses this week in the small city of Roanoke. There's a bad spike going on. So there's so much work to be done. And as my friends point out in this work, there is the sobering reality that many people who have histories overdosing are simply no longer alive. That's another thing to think about when you read about the numbers. So I'm going to talk about both opioid books today. Dopesick was a look at how the crisis got going back to the early days of OxyContin and then morphing into heroin and fentanyl epidemic. And Raising Lazarus is really about on-the-ground solutions to the problem. But the big picture as I see it, and it really hasn't changed that much since 2012 when I first, as a Roanoke Times newspaper reporter, started writing about the opioid crisis. We didn't even call it that then. was that it's still festering. It's still taking advantage of longstanding fissures in American society, of a nation that sent jobs away but did very little for the people that were left behind. And I'm going to talk a lot about that in my next book. And of the fundamental philosophical difference between law enforcement and medicine, between punishing the addicted and getting them treatment for their treatable medical condition. What we're doing isn't working. So I'm a story gal. I like stories a lot better than numbers, but I'm going to give you one slide of spinach with numbers, okay? And then I'll tell you stories that show why these numbers are important. So I already went over the latest drug OD data. The study I got from John Kelly at Harvard, Addiction is a Chronic Relapsing Disease. And this is the first one that made me really understand how hard it is for folks to get. I was seeing it on the ground, but to see it in the numbers in one sentence was like, wow, this is exactly what I'm seeing. It takes 4 to 5 treatment episodes over an average of 8 years for a person with a general SUD to get 1 year of sobriety. If it's OUD, it takes 2 more years longer than that, because generally folks lose so much of their social capital, homes, etc. So it takes even longer to get out of that. The treatment gap has remained at 87%, and that means that only 13% of Americans with OUD managed to get care in the past year. We know that buprenorphine and methadone are the gold standards of care. They're still really hard to get in rehabs, really hard to access in many jails. Even drug courts in Roanoke, my own city, doesn't allow participants to be on MAT. Now, that's not true of all drug courts, but just to show you how politically ingrained this idea that, you can't give a person with a drug addiction another drug. It's just wrong. That is still so ingrained, particularly in law enforcement. So only 1/7 of folks with OUD receive methadone or buprenorphine. And we know this is really important. This is why I wanted to do the follow-up book. Even though I was so depressed at the end of Dopesick, my husband said, you should write a cookbook next. I was like, nobody's going to want me to write a cookbook. That as the opioid litigation money starts to trickle down to communities, we know that every dollar that actually gets to treatment can save the nation 12 or more on reduced criminal justice and healthcare costs. So we don't want this money going to more cop cars, is basically what I'm saying. And it is, in some places, going to cop cars and to big builder jails. To build bigger jails. You know what I meant. Roanoke City, where I live, the overdose rate is 3.5 times Virginia's. Not long ago, I learned that, not coincidentally, Roanoke City, which is about 100,000 people, has the highest number and the highest ratio of foster care cases in the state. Roanoke City, higher than Richmond, higher than Norfolk. Now, all those things I just told you about this place I love, no MAT in the jails, no MAT, no peers coming into the jails and helping folks and giving them Narcan and buprenorphine when they leave, a drug court judge that is so sure that he's right that it's just substituting one drug for another. I can tell you those two numbers are related. This is why we have a terrible foster care program. So this is the person that really helped me understand what dope sickness was. This is a woman named Tess Henry on the photo on the left, holding her baby. This is a 215 photo I took right after I met her. Her mom is a hospital nurse. Her dad is a surgeon. They had a vacation home on Bald Head Island. Every resource that you could think of that would be, you would think she would have a better chance of getting out of her addiction. I want to tell you how she initially got addicted. She went to an urgent care center for a case of bronchitis, and she left with two 30-day, this was 2012, she left with two 30-day opioid prescriptions. One was hydrocodone for sore throat pain, and the other was Tussie Caps for a cough. At the end of 30 days, when they wouldn't give her any more meds, she was super kind of shaky and jittery. And she said, I put my symptoms into Google and I said, holy crap, I'm addicted. And she went to a friend who got her more pills. And when the pills eventually dried up, the same friend introduced her to a dealer who got her started on heroin. And as she wrote in her journal at that time, I was in love like never before. So I watched as she bounced from rehab to outpatient program to losing custody of her son to being homeless, and eventually, as so many people do, turning to sex work as a way to survive and not to be dope sick. I followed her for about 2 years. Towards the end of that, her mother and her granddad and some well-meaning recovery advocates in town who were very opposed to MAT sent her to a rehab in Las Vegas. It was right after that picture was taken. Her family was pro-NA and AA, which at the time were very anti-MAT, and Tess got no evidence-based treatment in Las Vegas. No follow-up at all. And when she bombed out of that, she was on the streets again, but she was in Roanoke. She was in Las Vegas this time, which was a lot different than Roanoke. It was a lot bigger, a lot rougher. She soon became involved in the sex trade there, was caught up in some gangs, we think. And when the autopsy on her body was made, she had 17 different drugs in her system. She had applied for Medicaid in Nevada, and she had called ahead to Roanoke. She really was desperate to get home to get custody of her son again. And she didn't have an ID or a way to get home, a way to get on a plane. She didn't want to be dope sick on the bus, which would have been a 3-day drive. And the last time I talked to her was a couple weeks before Christmas. She told me she already knew the hours, which days they were taking new patients at the methadone clinic in Roanoke. And her body was found in a dumpster on Christmas Eve that year. A month later, her Medicaid card landed in a friend's mailbox that would have given her access to treatment. The only needle exchange in Las Vegas that we later found out was 2 bus rides away from the homeless encampments. At the time of her murder, she had been living in an abandoned minivan with a pimp. Now think about what I said with her at the beginning. She could have been any one of us in this room. Her dad, a very well-known breast cancer surgeon. Her mom, a hospital nurse. So much education and so much miseducation, if you will. So much stigma. So the other things I saw her wrestle with were just like basic getting on buprenorphine. You had to be our local community services board didn't allow it unless you tried their counseling first and failed. And failure in an era of fentanyl is death. There was a waiting list, 3 weeks long. There was, when she finally got into a doctor that would see her, the first appointment was $500 cash and $100 a week thereafter. And she had to go through all this drug testing. She had to go to NA meetings. I would go with her. She would get them to sign a form. but nobody would sponsor her because at the time she was on Suboxone and they considered that unclean. Can you imagine what that would feel like? You're going to this group for help, you're made to go, and then you're treated like crap when you go. So that picture on the right is her mother, and her mother, Pat, who is now raising her son, who is now, I think he's almost 11 now, cute as a button. And I really didn't want to write about this topic again, but as I went around talking about Dopesick and talking about Tess, we even did a follow-up podcast for Audible on what had happened to her. I started hearing things that were working, and I thought people need to know this. Because still, even today, how many years, almost 30 years after OxyContin came out in 1996, we still aren't talking about this scourge that is killing young people and middle-aged people right and left, right? We are still stigmatizing people. So I feel like the spirit of Tess is hanging over this book because the first time I met her, when she described being overprescribed at an urgent care center, she said, just very much in like frustration because she had seen so many closed doors, she said, what we need is urgent care for the addicted, a place where you can just go, just like you can at urgent care. You can walk in, you can get connected to maybe even housing, maybe even treatment. You can get your abscess fixed. She had been to the emergency room so many times. They had fixed her abscesses. They had fixed her overdoses, but they had never given her treatment beyond that, beyond a Xerox copy of the NA and AA meetings, which when she went, gave her exactly the wrong advice. So how do we get urgent care for the addicted? That is really the story of raising Lazarus. That's the story I'm trying to answer. And when I will go out and do my research based on people who were figuring out how to do that, I was really interested in places where they had managed to overcome stigma and talk people in charge into doing the right things. So these are the Doctors Hartman. They're a married couple in Roanoke. They were really the first MAT champions. He's a blind psychiatrist on the right, the first in the Valley to do addiction medicine. This is his wife, Sherry. She's a psychologist. They run the OBOT, the outpatient MAT program. And they're the ones that had the 3-week waiting list when Tess was on the streets. But they went to bat with Carilion, the huge nonprofit hospital system in the western half of the state. And they talked folks into taking it seriously. So I told you Tess would go to the ER from time to time. About 2 years after Dopesick came out, I heard they had changed their mind. And I interviewed the head of the emergency department, John Burton, who was head of 5 different EDs in the different hospitals. And he had changed his mind, and they had started doing ED buprenorphine in the ED. So they would fix whatever, you would come there immediately. They would get you on a few days worth. You would get a peer support specialist to kind of walk you through the steps until your appointment with the Hartman's clinic, which would be in 2 to 3 days. I mean, this is evidence-based care. And it was working right away, very high retention rates. And I said, Dr. Burton, what happened? The last time I interviewed you, you thought it was just treating addiction with another drug. You thought it was not our purview, not our job. Leave that to the addiction docs. I said, what happened to change your mind? Because I really wanted to know how to make social systemic change. And he said, well, we read your book, and then we looked at the data. Yale had data on this going back to 2016. A doctor in their own facility had done some cutting edge research in the 1980s on the efficacy of buprenorphine. But they just then looked at the data, and by golly, they changed their tune on it. And they stopped seeing the same people cycle in and out of the ED. And you can hear, I record all my interviews, you can hear the difference in his voice and tone the first time I talked to him when he was very pessimistic, and the second time when he was like, damn, this really works. And I said, what's it feel like? In the first month alone, they got 34 people into treatment. He says, I feel like doing mental cartwheels every day. So you saw, like, this is why I got into this. Really cool field, right? But he had no idea. So these two really stepped up and they became leaders in their community and build coalitions. And I'm just so proud to know them. They retired recently, which is bad, but they're leaving a huge legacy behind. But every time I saw that in my reporting, it would be somebody who was just so frustrated. I met a doctor, an OBGYN in Peoria, Illinois, named Tammy Olt, who lost her son. He was 16 years old. She didn't even know he was drinking, and she lost him to a heroin overdose. She started a harm reduction group named for him in Peoria, and she couldn't get any of the docs there to do MAT, so she started an MAT clinic in her OBGYN office. It was her first time treating men. And as one of her employees told me, she said, there's something about being a grieving mother that kept the NIMBYs in the community from going against her, that kept them from being full-on assholes. She used her voice. She wasn't just a grieving mother. She was a doctor with a lot of heft, but the grieving mother and that voice that it gave her was what allowed her to change that. I mean, think about that. In her grief, that's what she did. No other OBGYNs that she knew did buprenorphine. Why? I mean, that's the question. There's a great quote from a Harvard doctor. You probably all know it. I'm going to say it just in case you don't. Because I told a young doctor this quote recently, and she was like, damn, I'm going to have that cross-stitch hung on my wall. The quote is, for the secret of patient care, does anybody know the rest of the quote? Is to care for the patient. The secret of patient care is to care for the patient. So in both of those cases, it was the thinking that had changed the practice, the exception that these addicted people were patients worthy of medical care and not just addicts. And what I love about Dr. Burton back in Roanoke is that he admitted he was wrong. He did the research, he admitted he was wrong, and now he's out teaching other hospital administrators how to do this. We did this, the world didn't end, and we're having really good results. But there's so much stigma in the healthcare system, from doctors who refuse to get involved with those patients, to cranky lab techs, mean people at the front desks. A friend of mine in Roanoke just lost a friend of his to end-stage endocarditis because she'd been treated like shit at the hospital so many times before, and she preferred to just stay at home and die alone. She was 27. So this is the arm of one of my favorite humans. Her name is Reverend Michelle Mathis. She and her wife Karen Lowe run what they call in Hickory, North Carolina, the nation's only, or they don't say only, they say it's the nation's first queer, biracial, faith-based harm reduction group. Say that 3 times real fast. And they started out, it was really a mission of theirs. They started out passing out food in parking lots to hungry people in a distressed small community of North Carolina. This was 2010. Needle exchange wasn't legal then. They're passing out food, and it took them about a week to realize that the folks coming for food, about half of them were IV injectors. So then they figured out, because they're smart, that if you pour out half of a box of Nature's Valley granola bars, 10 syringes fit inside that box really well. So they would tape over the ends of the box that they had doctored with needles. And they would also pass out things like socks and toiletries. And they would put a little card in that said Olive Branch Ministries and the phone number, so that if a relative found this card on their desk, they would say, oh, how nice, they're going to church. but the card was really so you could call them and they would bring you needles, right? And so they were poised after when North Carolina finally did legalize needle exchange to become a full service harm reduction provider. And this is Michelle's arm with a tattoo that says acta non verba, which is Latin, she says, for do shit, don't just talk about it. By the time I met her, they were poised. They had 3 different bricks and mortar needle exchanges in that entire Western North Carolina region. They had peers going out in their cars, treating people wherever they were, including under bridges. They would bring them food, clean needles, connections to care, because they know that people who use needle exchange services are 5 times more likely to eventually enter care. They brought cat food to this woman who was living in a tent with her cat. And the first time I went out with them, I was kind of new to this whole concept. I said, well, you didn't really talk to them about getting into treatment. And she goes, yeah, I don't talk to them about that until they're ready to talk to about it. And I was like, really? And I'm just thinking, I'm kind of pushy and like, when you want to push this, tell them that you have connection to that. She said, no, they have been so pushed out of healthcare. They feel so stigmatized that we wait till they're ready. First, the most important thing is to build trust in this community. And then I got to see why that was so important. You know, we have spent 2 decades kicking them out of our systems. There's no wonder they don't trust us. So the real focus was of this 40% of people with OUD who don't want to stop using, who've been so stigmatized out of even trying. So I forgot to tell you, but Jess, the woman in that photo, first met Michelle. She was in jail. She was shuffled in full shackles to an education class that Michelle was teaching in jail. And then eventually when she got out, she became a peer, and now she's a real leader in this community. And that is something that I see over and over and over. The peers are, I say they're like scar tissue. I have a scar from a surgery on my hand right here. It's like, it's tougher than the rest. And there is something about a person in recovery. I wish it was something you could prescribe, but these people, these peers, I call them my rowdy angels. They will do anything to help people. And this is a nurse practitioner who during the day works at a federally qualified health center in Morgantown, North Carolina. And at night, he volunteers with Olive Branch. And when I first started going down to report on Michelle and Olive Branch, she said, we're on the verge of offering low barrier MAT. I said, what's that? That's where we go to you where you are. And Tim, who's worked all day, mainly doing addiction and HIV work, at night, he starts passing out needles at truck stops along the interstate. He quickly realizes that because people are telling him, I think I have Hep C. So the next week he brings not just needles, but hepatitis C testing. And then the next week he brings the results, and then he funnels them in to a program to get Harvoni, the treatment for Hep C. And he starts to clear people's Hep C. And at one point, the woman in this home, her name is Mary Jo, says, Tim, how would it be, and she's just gotten cleared of her Hep C, how would it be if we started doing hepatitis C testing pizza parties at my house? And they thought that was the most creative thing they'd ever heard of. So off goes Tim with his bag. This reminds me of that famous W. Eugene Smith photo of the country doctor in the 50s. That's his doctor bag with all of his stuff. And he sets up a little mini lab in Mary Jo's kitchen. And all of her friends come. And some of them want to get connected to MAT. Almost all of them want to get tested. Some of them aren't sure they want to stop using. But that's the important thing, is to treat them like a human being anyway. So we were there, we watched, this guy told us he had just overdosed 2 days before. And the book, Raising Lazarus, begins with the scene of Tim, this nurse practitioner, at a McDonald's dumpster in Hickory, North Carolina. And there's a man who comes in a dented Jeep It's at the height of COVID. He's got a broken face mask on. He's late to the appointment with Tim. He says, he's crying. He says, if I don't stop injecting, I'm going to die. And Tim says, well, let's get you help, buddy. And he's going to call in a low cost prescription through the FQHC where he works during the day. And you see, like, he's like the glue between these disparate organizations. He's starting to make connections, just like the Burtons and the Hartmans did and Roanoke. And he says, but I want you to know two things. And these are really the themes of Raising Lazarus. One is you can get better. So, like, most people with addiction don't think they can. They're part of that 40%. Most people in America don't think they can. And two is just don't disappear. I'm going to meet you back here next Wednesday, same time. But if you can't make it because your car breaks down or whatever emergency happens, text me and I'll come to you. That's low barrier treatment. And we've got to start scaling that up to match the scale of the crisis. It's really hard to scale someone like Tim Nolan, who is a saint. He hates it when I call him a saint because he said, if you call me a saint, that makes other doctors and nurse practitioners think you'd have to be a saint to do what I do, and you don't have to be a saint to do this. I'm like, all right, chief. I'm still calling him a saint. So he invited me to come down and visit at his FQHC because he wanted me to meet a peer named Nicole. And she could have an office in the back like the other peer does, but she chooses to man the front desk. I'm just going to read a little bit of an exchange that I witnessed. In recovery for 7 years, Nicole has a sixth sense for what to say to broken down people approaching her front desk counter for the very first time. She gives new patients her direct phone number. Okay, when's the last time somebody at a doctor's office did that to you? I always get, where's your insurance card? That's no hello, where's your insurance card? She pulls the tearful ones aside and convinces them to be honest with their providers. Then she decides which practitioner they'll see based on whether she thinks they'd thrive better under Nolan's harm reduction approach or the other nurse practitioners whose style is stricter and more tough love. When 36-year-old Julie Steen first approached the clinic counter wearing an oversized pink t-shirt, Nicole noticed her hangdog look and gently asked, "What are you here for today, honey?" And Julie could only whisper, "It's awful." And Nicole said cheerfully, "I'm in recovery." And Julie said, "I'm an IV drug user. I don't work." And Nicole said again, "I'm in recovery. My children," and Julie said, "But I'm homeless. I live in a tent. My children are in another home." And Nicole said, "We want to see you." In the 4 hours I watched her man the front desk, she calmed down a psychotic patient who couldn't stop pacing and counseled an elderly man with dementia who'd just been discharged from the hospital and didn't remember how he'd gotten there. Between patients, she opened a new box of COVID vaccines. After a pharma sales rep dropped off lunch from Olive Garden for the staff, Nicole distributed the leftovers to patients in the waiting room. So, the update on Julie, the woman with the hang-down look, she's now been sober for 2 years. For the first time since she was 14 years old. She's in her late 30s. And Tim and I still text back and forth about the patients that I got to know that he works with. And the last time I asked him how Julie was doing, he wrote me this: "She's doing amazing. She is drug-free, working third shift in a convenience store, spending lots of time with her kids. She brought her 13-year-old daughter with her to see me, which by itself was amazing. She told her daughter, 'He used to come find me in the woods.'" I'm going to skip a couple of these. These are mainly about a different approach at Fairfax Detention Center. really good stuff, more about it in the book. I just want to leave time for questions. And I want to get to the power of one, which I want to talk to you about with the story of Nikki King, who was a young woman who grew up in Letcher County, Kentucky, kind of the font of the OxyContin epidemic. And among her first memories are going to friends' birthday parties and their mothers overdosing. And Nikki knew she needed to get out. She literally had to run away to go to college at the University of Kentucky. It's a story I tell in an article I did for The Atlantic several years back. And when I first met her, she was running mental health and addictions for a rural hospital in Batesville, Indiana. And the community had taken a vote on what their most pressing problem was. And Batesville was right in between Cincinnati and Indianapolis on what Indiana calls their heroin highway. And right near that county that had the huge spike in Opana, and when then Governor Mike Pence actually opened a needle exchange. So a real drug hotspot. And so all the grand poobahs of the county got together and said, we're going to deal with the opioid crisis. And Nikki, who at that point had spent her whole college career, she was now getting her PhD in addiction, studying evidence-based practices, marched up to the head judge and said, well, what are you doing with people when they get out of jail? And he said, well, they have, they get drug tested a lot, and when they fail, which they ultimately do when they're not getting treatment, they put them back in jail. So she said, we can do better than that. So she went to her boss, the hospital CEO, at a time when rural hospitals are closing right and left. And she said, if you let me design an evidence-based program for people coming in and out of jail, where our social workers work with them, do really intensive IOP. We do it at night. We help them get jobs during the day. We get them signed up for Medicaid. If we can do all this, then I will get this program cost neutral in 6 months. Indiana was a Medicaid expansion state. And the idea was they were going to use that money to pay for the extra counseling. And he said, okay, because she had already proven herself with other things in the hospital. And everything was going great. I mean, I spent weeks there. I got to know lots of her patients. I mean, they were people in their 20s and 30s who had spent their whole lives in and out of jail, many of them doing sex work. And the first meeting they all had ACE scores of 9 or 10. That's the highest you can get. Almost all of them had been molested and abused as children. She asked them what their goals were, and their goals were, one said he wanted to taste salmon for the first time. Another person said he wanted a second pair of pants. Yeah. And so this team of probation officers and court workers and scrappy social workers and Nikki at the hospital started doing all these things. Lo and behold, we can just buy a piece of salmon and a second pair of pants, and we can get these folks on MAT. And they hired peers to work with them. And 6 months into the program, they had not one overdose. Actually, after 18 months, they had not one overdose. They had a few relapses, but when somebody relapsed, they didn't automatically put them in jail. They increased their treatment, right? They didn't just put them in jail. And so 6 months in, they get a call from Indianapolis, and they said, sorry, guys, bad news. We can't reimburse you because you're not in a medical facility. That was a Medicaid, Section 15.B. And they're like, oh, we got to end the program. And Nikki did what any 28-year-old would do, who had worked 80 hours a week starting this program and was having really great results. She burst into tears, which made all the middle-aged men in the room really uncomfortable. And then they started brainstorming. They said, well, what if we have the program not in the courthouse where we've been having it, but what if we have it in another clinic nearby? And they're like, no, the whole thing works because finally the law enforcement is working with us and we're beginning to trust each other. and sharing in these good results. And Nikki thought about it for a minute and she said, I know. What if I buy part of the hospital? I'm sorry. What if I buy the courthouse? So for $25 a month, the county attorney got on board. The hospital rented part of the conference room they were already meeting in. They got the community service workers to come in on the weekend, build a wall and a door, put a sign up that said the name of the hospital, the name of the courthouse, Suite A, because they thought that sounded classier than Room 1. And suddenly it was a medical facility inside of a courthouse. Like, that's pretty basic, but it worked. So an update on Nikki. She is now running an FQHC in Fort Wayne, Indiana, is taking on a second location in Indianapolis. She's going great guns. She has a clinic for LGBTQ folks, including gender affirming care, addiction, foster care kids, immigration. She is on her toes at a really tough time in federal funding. And if anybody can figure this out, this is what the county of Ripley County, Indiana, where she was doing that amazing work for her PhD thesis, told me how she had recruited him because there were no psychiatrists in the county. She found out he was speaking at a conference and she arranged to sit next to him, and she just kept talking to him until he finally agreed to come to Batesville twice a week. And it was amazing. She figured out what moved him, and what moved him was the incredible needs that she was seeing, which he had never seen before to that level. And he's the one who said, you have to work in mental health, Beth, to fully understand that what she's done doesn't exist. And she's still doing that. So I'm going to just kind of wrap up. We need on-demand access to MAT with social supports. Harm reduction isn't harm eradication. It's a gateway to MAT, which is protective, and a gateway to treatment. Call it a pilot. I always say this to groups, especially if it's heavy on law enforcement, because a lot of people who are elected officials are afraid to try new things because they think it's going to make them sound, they call it hug a thug. But if you start something and you call it a pilot, and then you go back 6 months later and you say, here, look, here's actually the results. It can be very convincing to people. And I don't know, how many of y'all have seen the Dopesick show on Hulu? Great. So there's the Michael Keaton character is based on the story of Dr. Steve Lloyd from East Tennessee. And he worked with the judge that told me, call it a pilot, start out small, call it a pilot. And their first pilot was to bring Dr. Steve in, who was himself someone in recovery, and into the drug court. And they started doing evidence-based treatment. And it was dramatically reduced the number of babies born with NAS. Their OD deaths halved. And they started surrounding the people, much like Nikki's program, with social supports. Women get shit done. This is just something I noticed, that a lot of the women were leading these initiatives, and they were mothers and sisters of the dead. And so I was giving a version of this talk in Binghamton, New York, and I said, women get shit done. And there was a woman in the back going, yeah, we do. And at the book signing line afterwards, she came up and I said, I saw you nodding. And she's like, yeah. And so she told me the story of, she's a hospital executive. And, she goes to all these high-level meetings. And she started advocating in 2014 for an MAT clinic in the hospital. And she was told, no, we don't have the money, blah, blah, blah. And then her son died in 2016. And at that point, at all meetings thereafter, we were losing a person every 10 minutes And so every 10 minutes in her high-level meetings, she would stop whatever was going on and she would say, "We just lost another one. We just lost another one." And I was like, "Whoa." And she said, "And now I run the hospital's MAT clinic." The power of peers. I've already talked a lot about peers. Mary Jo, who was the woman in the house doing the hepatitis C testing party, she got out of care. She had a really rough year. She overdosed 100 times, was brought back by harm reduction every time. She eventually got into treatment and is now one of Tim's peers. And the first time I saw her after that, she had her kids with her and she said, "Look, I'm out in public with my kids and no court supervision." She said, "You didn't used to be able to see my eyes because I was high all the time. Now you can't see my eyes because I'm smiling all the time." We need stronger leadership at every level. Right now, with all these federal cuts, we need to fight just to hold on to what we have. Self-care, I'm always preaching self-care. That can be really hard when you're trying to hold on to your job. One of the things I've been talking about is I've got a new Substack. I'm writing these newsletters as in the run-up to my new book coming out. It's really about working action and or advocacy, a lot of which I've learned through my reporting on Raising Lazarus, working that into your weekly routine if you can. I talked about packing Narcan kits on Mondays. Just being out there in the community, distributing diapers, delivering food through your church, whatever it is your jam. We all need to be building alliances in our groups. We need to make different areas of our lives talk to each other. Because this is what we're in now, a full-blown authoritarian cataclysm, in my opinion. People with social capital in our communities, people whose salaries don't depend on federal funding, people like me, maybe people like you, we're the ones that are going to have to become the activists. So I talked about Nikki being the power of one. Last week I gave a talk at a facility for women and children in recovery in Roanoke. And it's this wonderful collaboration. It's started by an OBGYN who figured out she wasn't going to let that opioid litigation money go to cop cars. And she got the funding. She partnered with Carillion and this badass woman who does a lot of redevelopment, and they opened the center. And this is a place that would have saved Tessa's life, I have no doubt, because she really was inspired to get better and to get custody of her son. So exactly 10 years after I met her, Roanoke is finally offering a little piece of evidence-based care that would have caught someone like Tess. There's a new program I just joined the board of. It's called Huddle Up Moms, started by a very busy OBGYN. Boy, I'm noticing a theme here. Who realized she's the only OBGYN in Roanoke who will see the worst of the worst sexual abuse cases. She's doing surgeries a lot on children who have been sexually abused. And told you about the skyrocketing foster care rate. She started this nonprofit on her own. And, you know, if you want something done, give it to a busy person. And it's basically, she realized that the moms were lonely, especially the low-wage moms. She started support groups, so wraparound services, a diaper bank, a formula bank. It's really amazing what she's done. That would have helped Tess. That's why I'm on the board of it. This is what would have helped Tess. She saw a need and she got it done. So lastly, if you know people who are still putting up barriers to care, whether it's judges, probation officers, politicians, medical administrators, talk to them. Tell them some of these stories. And what I've learned from these people and others is that change happens when people get out of their silos and really get to know other people, educating people. And when people with status in their community stand up for the least among us, their peers pay attention. So we can do that. And if the naysayers see the successes that can come from it, they can be just like Dr. Burton. They can be doing mental cartwheels too. So thank you so much. I'm honored to be here. I'm honored to be here with Sanjay and Margaret. Sanjay was one of the people who, just a quick story, Roanoke finally got a needle exchange a couple years after it was finally approved in Virginia. But the law as it was written back then was the police chief and the city council have to sign off. Roanoke is a blue dot. So the city council was no problem. They signed off. The police chief said, and I quote, told the newspaper, well, if we give out needles, we might as well give out marijuana cigarettes in the elementary schoolyard. He told the newspaper that. I had a lot of fun with that. So Sanjay was a med student at Harvard at the time, Margaret's husband, not yet Margaret's husband, but soon to be. We wrote an op-ed. We co-wrote an op-ed that ran in Virginia's newspapers. We met with the city manager. I don't know that we helped get it passed, but we kept the pressure on. And that's what it takes in this day and age. But I won't talk anymore. I know you have questions. Thank you for having me.
If anyone has questions, I'll pass around the mic. This room's for hands.
Well, any questions online? Okay, great.
Hi, thank you so much for being here today. I really enjoyed your talk. I was wondering if in your reporting and your research and just having relationships with so many people, if you've found that groups like AA and NA are more receptive of MEC now. Yeah.
Particularly NA. One of the people I met when one of the ways I would keep in touch with Tess when I first met her, at the moment she was living with her baby and her mother. And a condition of her MAT is she had to go to NA every week. So I would pick her up on Sundays and we'd go to this 2 p.m. meeting. And the guy running it was this older African-American gentleman who had been in recovery for 25 years. And he was actually a Suboxone group leader for a treatment provider. But he still ran NA meetings. And at the time, NA back in 2015, 16, they were kind of looked askance at it. And that was the meeting where someone else wouldn't sponsor Tess. And by the next year, they were already changing their policies. He said people died because of that.
Thank you.
Yeah, thanks.
I'll ask a question while people are.
Oh, we have a question there. Okay.
Yeah.
Please. Hi, thank you for your talk. My name is Kelly Gerker. I'm an associate professor in the Department of Pediatrics and an epidemiologist by training who's worked on opioid projects for, I don't know, over 10 years now. And I'm concerned given the outbreak started among white, to be frank, largely folks, and that now as we're finally seeing a little decline in fatal overdoses at least, but the demographics are shifting to a more minority, that we're not seeing the same declines across demographic groups. I'm just wondering if you could comment on, or if you have any ideas about my fear that because of those shifts in the demographics that we are at risk of losing the momentum and this huge bolus of funding through the HEAL initiative and all these other sources, particularly in this, what seems to be the advent of a maybe more resource restricted environment, what your thoughts are on how we maintain momentum and keep a spotlight on the issue, given the shift in who is more affected or is going to be more affected moving forward.
Right. You're absolutely right about it started out, and I get that all the time. Like, nobody cared when it was Black people dying in the crack epidemic, and now we care because it's, I'm very worried about the cuts. We know that if we made methadone easier to access, if you could just go to the pharmacy and get it, for instance, if you could get weekly take-homes, which all these things we did during COVID, if we kept that, if we made methadone, which is more efficacious in the era of fentanyl and the xylazine and these other things, that we could make a dent in that. Buprenorphine is easier to get. African Americans in many places have greater access to methadone. So we really need to relax those rules around methadone. I mean, the problem was that drug addiction treatment grew up as sort of the stepchild of the healthcare system and remains that. Exactly. There's so many counties that have no buprenorphine providers still, right? And if we're talking about Medicaid and cutting SAMHSA, I mean, that number is just going to go up. It's going to be way higher than 100,000. So, I mean, I'm sorry to say this. You probably don't want me to get political. We haven't talked about this. I had to sign a thing saying that I don't take money from Purdue or the makers of buprenorphine, but I didn't have to sign anything saying I wasn't going to answer your question, honestly. And I think we've got to get to the streets on this. I have a child on Medicaid, a 26-year-old traveling musician. Medicaid keeps them going. Exactly. Good. That's really important. I mean, the emergency is now. We're in it. We're really in it. And don't buy that bullshit about it's the immigrants causing this problem. I mean, it's just crazy to me that they can blame it all on immigrants and or say tariffs are going to fix all this when I'm getting off the track of medicine, but tariffs are going to fix it and bring America roaring back when every factory I go to in my hometown in Ohio is hard up for employees. And by the way, they're busing in Haitian immigrants from Springfield where they're eating the pets, they're eating the cats. That's the only way these factories are operating at all. I'm getting worked up. I'll stop.
I think we're at time. Thank you so much. I don't think we all love when you get worked up, but thank you for not holding back and speaking the truth. That was really, really wonderful. Thank you.